Welcome to the Neuromodulation podcast, presented to you by the International Neuromodulation Society. Dive into the forefront of today's emerging neuromodulation techniques, insights, and ethical and clinical applications. Subscribe now to join the multidisciplinary collaboration of medical care providers, scientists, and engineers who are part of the global conversation that's shaping the future of healthcare. Welcome to the Biostatistics articles live reading series, presented by the International Neuromodulation Society and developed in collaboration with the Newcastle Cognition Lab at the University of Newcastle. I'm your host, Mandy Soleil, and it's a pleasure to have you here. We're pleased to offer this ongoing series of short articles explaining how to critically apprise clinically relevant literature to evaluate evidence and inform practice. The entire series of articles is available on our website at www.neuromodulation.com/biostatistics-articles, and a direct link to this article is available in the episode show notes. We've translated each article to a live episode on the Neuromodulation podcast to bring versatility and ease to your statistics learning journey. Each primer features a single topic and an example within the context of clinical neuromodulation research and practice. Upon reading and/or listening to these articles, learners will be able to understand statistical methods, their interpretation and their limitations, identify cognitive biases to avoid inadvertently misinterpreting evidence, and interpret data for a deeper understanding of clinical research to inform clinical practice. And now, I present to you Professor Konstantin Slavin, head of the Stereotactic and Functional Neurosurgery section at the University of Illinois Chicago, or UIC, and president-elect of the INS. His term as president begins September 1st, 2024. Thank you for tuning in.
The third installment among the biostatistic articles written for International Neuromodulation Society deals with N-of-1 trials and their use in neuromodulation. It is written by Garston Liang, Quentin Gronau, and Alexander Thorpe. The caveat of the paper is that N-of-1 trials are a personalized method for investigating treatment effects in an individuals. What's to carefully consider? Any generalization beyond the specific individual, the double-blinding protocol, and carry-over effects and wash-in periods for pharmaceutical interventions. Introduction. An older friend once said that one really starts to feel their age when you know your good knee from your bad knee. Only problem was, years of basketball had left me with exactly 0 good knees, and so I had much to ponder when consulting my doctor about the inflammatory pain in my legs. At this point, knee pain is not a new phenomenon. There are many different treatments, for which some treatments work better for some individuals, and so how to choose amongst the options was my particular problem. Here, N-of-1 trial has much to offer. The N-of-1 trial folds into the philosophy of personalized medicine and takes an experimentation framework to identifying treatment efficacy for an individual patient. For example, suppose we use an N-of-1 trial to determine the efficacy of nonsteroid anti-inflammatory drug, NSAIDs, for my knees. A pharmacist creates a set of placebo tablets indistinguishable from NSAIDs, and a regime that alternates placebo and treatments. Over weeks and blind to the drug regime, a patient would provide repeated outcome data to determine the efficacy directly and experimentally. In this primer, we explore how the N-of-1 trial places the individual's outcomes at center stage and highlight the design and statistical considerations in both clinical and research contexts. Part 1. What is the N-of-1 trial? The N-of-1 trial is a systematic method where the patient receives repeated cycles of treatment and placebo interventions called crossovers. It's illustrated in Figure 1. The N-of-1 trials establishes the efficacy of a treatment by administering multiple crossovers, at least 2, and comparing patient outcomes during each phase over time. The benefit of this individualized method is that each patient serves as their own control, and so treatment decisions can be tailored to each patient's unique outcomes. N-of-1 trials have been used to to investigate a range of treatments for chronic disorders such as osteoarthritis and cystic fibrosis, and are classified as the highest level of evidence for assessing treatment benefits alongside systematic reviews of randomized controlled trials by the Oxford Center for Evidence-Based Medicine. Part 2. For whom is it for? N-of-1 trials are well suited for patients with stable symptoms, such as those with chronic disorders. The personalized focus makes N-of-1 trials an option for individuals that are underserved by randomized controlled trials, RCTs. This may include individuals or a group of individuals that are typically excluded from the population pool due to comorbidities that meaningfully differ from the tested RCT population, or cases where a low prevalence rate means RCTs are not feasible. More broadly, advocates of N-of-1 trials envisioned that the design would be beneficial in drug treatments and development. Prior to large-scale testing, N-of-1 trials could serve as an alternative for identifying the range of treatment effects associated with specific patient profiles. Part 3. Key features of the N-of-1 trial. Across clinical and research settings, there are several key features common to an N-of-1 trial. N-of-1 trials must be double-blinded, such that both patient and clinician are unaware of which phase is being administered. The personalized nature of the testing makes double-blinding essential. Within the trial, a crossover is typically a single paired alternation between the treatment and placebo phases, and each trial should contain multiple crossovers. For an individual patient, the sequence of crossover pairings can be randomized a priori and counterbalanced. For example, ABBA, as in Trial 1 of Figure 1, to take in consideration the passage of time. In a research setting where multiple N-of-1 trials are run simultaneously, the sequences across all patients should be counterbalanced to avoid drawing inferences that are dependent upon an idiosyncratic crossover sequence. Importantly, the trial should be designed to avoid carryover effects between the data points. Consideration of the wash-in period is necessary to avoid contamination between time points. This might be particularly relevant for pharmacological interventions that take time to take effect. Conversely, it may also be necessary to consider a wash-out period after an intervention is administered to protect against intervention carryover into control phases. These temporal precautions are necessary to ensure that data from each phase do not cross-contaminate and dilute the measurement of the intervention. Part 3.1. Consideration for statistical analysis. N-of-1 trials have been conducted in both clinical and research settings, and the choice of statistical analysis depends on the goal of the trial. If the goal is to determine the best treatment for a specific individual, as is the case of the family doctor and the patient, then statistical analysis is not needed at all. The patient and the doctor can decide whether the effects of treatment for that individual were meaningful. Written reports of N-of-1 trials can be then interpreted like a case study, and the data may involve visually interpreting trends or comparing simple means. To extrapolate beyond individual cases to a population, however, both the analysis and the trial should be carefully constructed to ensure that inferences are statistically warranted. Part 3.2. Data collection and choice of statistical model. A core issue for N-of-1 trials is the large variability of outcomes that an individual might experience. This has implications for data collection in both research and clinical contexts. For the clinical context, the patient and clinician might decide to measure multiple outcomes over the course of the trial to capture the personally important features of the treatment. In the research context, where multiple participants complete trial in parallel, it is important that the choice of outcomes is consistent across all individuals. For data presentation, these data are often shown graphically across the phases, as in Figure 1, and where multiple individuals participated, care should be taken in aggregating outcome data across subjects, but in particular over time. Simple statistical tests, such as signed difference or paired samples t-tests, may collapse data across the phases, and so time, and compare mean outcomes values. However, one should treat these statistics with caution because of the strong degree of autocorrelation between each data point. This means that data is collected from each person sequentially, and so the data violates the assumption of independence. Ideally, the statistical model should account for autocorrelation, such as in time series analysis, or explicitly incorporate the passage of time into the analysis. The figure 1 illustrates hypothetical data of different N-of-1 trials. There are two plots with a treatment and control series going in different sequences. So for trial A, there's a control treatment, active treatment again, and then control treatment again. Whereas for trial B, it's alternating between control and treatment 3 times in a row. For trial C, which is multi-participant trial of N-of-1 trials, there are 4 different patients, with one being tested in the sequence of control, treatment, control, treatment. The second one has control, treatment, treatment, control. And the third one, once again, has control, treatment, and the fourth one, control, treatment, control. This hypothetical data of different N1 trials, and across each plot, the blinded intervention, either treatment or control, and measurements are taken on a daily basis. For clinical examples, trial A and B show that N-of-1 trial sequences for individual patients, with trial A showing 2 crossovers between treatment and control phases in the ordering ABBA. Trial B shows 3 crossovers, and the ordering is AB. Trial C demonstrates how N-of-1 trials can be scaled in research settings to multiple participants across counterbalanced orderings in order to make inferences beyond the individual patient. Recommended further reading. There are 3 resources to discuss N-of-1 trials in greater detail. They include the paper by Mendonça in the Frontiers of Human Neurosciences, published in 2022, by Gabler and colleagues on a review of N-of-1 trials in medical literature, published in Medical Care in 2011, and the special issue series of N-of-1 trial in the Journal of Clinical Epidemiology, especially the papers published under editing of Natnaras and Tugwell in 2016. Thank you.